So chest tubes, guys. We I don't know, we do a lot of chest tubes, don't we? So I don't have my Plurivac, which is kind of sad, but that's okay. So I'm going to show you first the actual tube itself, because I need you guys to understand this concept. So here's your actual thoracostomy tube. And so if you can see on here, it's going to tell you the size of the tube. All right, so that's important. So in trauma, we like to use bigger tubes just because we're going after typically blood products in the chest, theoretically. So I like a 32. 28 in trauma would be the smallest one I would want to put in. And then typically we go up to like a 40. And then there's straight, which this is a straight tube, or curved tubes. That doesn't really matter so much. What's important though to take note, especially so in chest tubes and in nasogastric tubes, there's what we call the sentinel hole. So do you guys appreciate what that is? So the sentinel hole is the first break in the radio-opaque stripe here. And what does that correlate with?
The measurement, the lines?
So it actually, yes, it does correlate with the measurement, because that was a kind of something that the guys and girls yesterday weren't too sure on. So your measurements here are from the sentinel hole. They're not from the tip of the tube. So if you're like, oh, I'm in at 10, well, you're really in about, I don't know, 15 or whatever, more than that. Because look here, this amount here is is another 10, right? So this is from the sentinel hole, okay? And the sentinel hole is the last or first, depending on how you want to think about it, fenestration in the tube. So that is important because on an X-ray, you have to make sure that that's actually in the chest. Okay, that is like the critical thing. And so the same holds true with this sentinel hole on an NG tube or OG tube, because that sentinel hole has to be in the stomach. Okay, if it's up here in the goose, no good. If this is out of the chest, no good. Okay, so that's the tube itself. Now, technique is going to be 4th or 5th intercostal space in the mid-axillary line. You're going to anesthetize the patient for sure if they're awake, because this is very painful. So you anesthetize the skin, and then I like doing a little block as well, where you would go and kind of do a little intercostal block on the periosteum of the bone, okay, on the rib. So then you'd make your incision, which was already made here, and you would bluntly dissect the subcutaneous tissues, and then the important part would be going, do you want to go over the rib or under the rib? Over. Yeah, you go over the rib because of the neurovascular bundle there. So boom, over the rib, spread. You theoretically might have blood come out or hear air rushing out of the chest if there's that either pneumothorax or hemothorax. You spread, okay? Then important, you introduce your finger into the chest and you do a finger sweep here, making sure that the lung, especially in an old patient, maybe they have blebs, maybe they have COPD, maybe they had cancer, maybe they had a lung resection, who knows, right? You might not know all this stuff. To feel, and this mannequin is super realistic because you can feel the lung there, okay? So you do that finger sweep, then you load your thoracostomy tube onto your Kelly clamp. I like to load it like so. I've seen a lot of different things where people like doing these types of things. I don't like that. I like to have this thing like beautifully on the tip of that tube, and then bam, introduce it right into the chest, and then suture it to the chest. Another important thing is when we suture this thing onto the chest, people like to do this Roman sandal majigger thing, the worst thing you can possibly do. Because I put a suture in the skin here, and then if I'm doing that like Roman sandal thing and I tie it here, the second that knot gets even the slightest bit loose, all of a sudden there's a bunch of slack in this and it'll fall right out. We've seen that just so many times from, say, like an outside facility or whatever. The chest tube is not sutured inappropriately. So what I always recommend, you suture it to the skin, and then you wrap it around the tubing, and that wrapped suture stays in the same exact spot right here. So there's zero slack in it. And you tie it down, and then you do it again, and you tie it down right here. The Roman sandal is going to cause laxity and a lot of length in the suture, and it's going to fall out 9 out of 10 times. That is critical for tying this thing in. And then for our dressing, you put a vaso-occlusive dressing around here, or a xeroform, because what we don't want is air sucking into the chest wound here. So you put a vaso-occlusive dressing and then a 4x4 typically in tape, okay? And then you hook this up to your Pleurovac, which unfortunately we don't have today, okay? Oh my God, it looks like there's blood in there. So, all right. So I want you guys to do this, and I want everyone to at least put their finger in there to feel, because this feels extremely realistic.